Are we live, ya Ahmed, now?
Yes.
طيب. بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. بدء الجمعية السعودية طب وزراعة الكلى ترحب بالجميع. So in the beginning, I would like to welcome everybody, and this is the commitment of the Saudi Society of Nephrology and Transplantation to continue doing the educational sessions even during the pandemic of COVID-19. This is number 6 webinar since Ramadan. We start this chain of webinars with speakers from North America, Europe, and as well as the Middle East. So I'm very happy to continue this chain of webinars. Till next week, we have another webinar about the new modalities in management of hyperphosphatemia. And the thing that I'm very happy to announce that, as you remember, our congress that's supposed to be happened in last April, which is the critical care nephrology and hemodialysis. And it is now, the date is already announced. It will be on 17 to 19 of September this year. It will be completely virtual meetings, including virtual loopy, virtual exhibition hall of all sponsor companies. You can communicate with the sponsor companies by chat, by live videos, and as well as there will be parallel sessions. We have speakers from most of the globes. They will talk about up-to-date about the critical care nephrology and hemodialysis. Also after that, we will have what we promised about the big congress also will be on peritoneal dialysis. This is will be on November this year, inshallah. Again, it will be a completely virtual conference. So without any delay, initially I would like to thank our sponsoring company for this event, the Biologics, Ustad Dr. Omar. Without their support, as usual, of our collaborations of the companies, those webinars cannot be happened. So I would like to thank Biologics again. And without any delay, I will give the mics to my colleague, Professor Isam Al-Sabban. He's the moderator of this session. Welcome, Dr. Isam.
Thank you. Bismillah ar-Rahman ar-Rahim wa salatu wassalam ala Rasulillah. First of all, it's my pleasure to participate with my associate in this scientific evening, as well as with the participants across the world. This evening, we have a very interesting, special topic to be discussed. It's nephropathic cystinosis. And before we proceed, I would like to remind the participant that you have in the Q&A page, you can paste your question, and we'll be more than happy to entertain the answers from Professor Dieter Hafner at the end of the lecture. And I hope that you will find this night is very helpful and very informative and very down to the scientific basic that everybody is interested in. Having said that, let me introduce my colleague, Professor Dieter Hafner. He is the professor and head of Department of Pediatrics, Kidney, Liver, and Metabolic Disease at Hanover Medical School. Is well-known worldwide figure in this field of nephrology, as well as in the metabolic diseases. And his interest is cardiovascular as well as bone diseases with end-stage renal disease. Also, he's the head of the clinical guidelines in IPNA, International Pediatric Nephrology Association, which is a very valuable resource. And I'm sure it's going to, this committee is going to help worldwide to straighten out our approach to management in different kidney diseases. Without further ado, I would like to welcome Professor Hafner. Dieter, it's your turn.
Thank you very much, Dr. Saban, for this kind introduction. And I would like to thank your society for inviting me the third time to a meeting, the first virtual meeting. And I'm really delighted and I'm very proud. And it's a great honor to give this talk to your audience. So I just share my screen and it works. So that's not my home, that's the castle in Hanover. And whoops. Here it goes. So let's start. So the talk is about cystinosis and diagnosis and treatment and outcome. First slide, just some disclosures you may appreciate. And then the outline of my talk, I will talk a little bit on the natural history, talk a little bit on pathophysiology, diagnosis, and the major focus of my talk will be on the management, especially with respect to the kidney disease, the specific treatment with cysteamine. I will give you a brief outlook on the renal outcome in 2020. And then the next will be on the cystinosis metabolic bone disease, which is a tricky disease to treat in cystinosis patients, and also give you an outlook on the actual outcome in patients. We just did a multi-center study on this topic. So what about the national history of patients with cystinosis? So in the last century, in early last century, this was really a nightmare. Patients had severe Fanconi syndrome and died early due to dehydration and electrolyte disturbances. Later on, the 50s and 60s, IV needles became available. Patients could be treated with IV solutions if they get severely dehydrated. Nevertheless, if patients were born before the 70th or last century, patients usually died due to end-stage renal disease. So the natural cause of the disease is end-stage renal disease at around the age of 10 years. After the 80s, in most countries, cysteamine treatment became available. By using this, there was a possibility for preservation of kidney function until adolescence or young adult age. Now in the 21st century, with the novel area, the oldest patients are now 55 years old. It's unbelievable. There's improving existing therapy, and there's a search for curative therapies as well. And, however, today I will not focus on future therapies. I will rather focus on what is available now. However, the challenges are we have a growing population of adult cystinosis patients. That's why the moderator today is adult nephrologist. I'm a pediatric nephrologist, so we can only manage those patients probably if we take care for the children and adults, and we need a transition program for those patients. We have to take care for issues of quality of life, and major problem, we would say in Germany, the English people would say a challenge is the adherence, or formerly known as compliance. So cystinosis is an autosomal recessive disease caused by lysosomal accumulation of cystine due to the defective exodus of cystine out of the lysosomes. So it's a lysosomal storage disease. Since lysosomes are in every cells, it's a systemic disease, and we can say that every organ in the body can be affected by this disease. The incidence is around 1 to 100 up to 200,000 newborns. There are some clusterings around, and the most common cause of it's the most common cause of inherited generalized proximal tubular dysfunction, which is named as renal Fanconi syndrome, and it progresses to end-stage kidney disease. So the kidney is the first diseased organ, which is largely explained by the affection of mitochondrials. And since the proximal tubule need a lot of energy, it's a simple explanation why the kidney is the first organ which gets a dysfunction. So cystinosis gene is cystinosin encodes for a protein. It's a transport protein in the lysosome. That's the cell, that's the lysosome, that's the mitochondrium. And you see that the cystosin is a transmembrane protein, which is in the end a proton-driven cystine transporter. Cysteine is a complex of 2 amino acids, which their name is cysteine. If they get combined, it's cysteine, and usually it's transported out of the lysosome by this protein. And if the patients have a lack of this protein function, cysteine accumulates in the lysosomes. And unfortunately, cysteine is insoluble and it forms crystals. And formerly it was thought that the crystal deposition causes the damage of the cells. But that's not a good correlation between the cysteine content or the amount of crystals in the cell and the organ dysfunction. So people search for other causes of the cell damage. And we know now that the accumulation of cysteine results in altered mitochondrial energy metabolism. For example, there's a decreased ATP content in the cells. We have increased oxidation indicated by increased ROS, and we have very high levels of autophagy and apoptosis. Please remember, if we treat patients with cysteamine, the autophagy, the increased autophagy does not get corrected. So the new treatments, which now hopefully will available for clinical practice in some years, will probably focus on the amelioration of autophagy, like done by mTOR inhibitors. Anyway, the most common mutation in North Europe, where I'm living, is the 5-7 kilobyte deletion, which is quite common in our population in North Europe. About 1/3 of our patients are homozygous mutation for this deletion, and 1/3 are compound heterozygous, and 1/3 of patients in our region have other mutations. There's no real hotspot for the mutations, and so far, there are more than 100 mutations are described. In more than 95% of the patients, we can confirm the diagnosis of cystinosis by genetic analysis. A lot of kinds of mutation, and as all for other diseases, there's a weak, but there's some kind of genotype-phenotype correlation. For example, truncating mutations, which lead to a shortened protein with a rather residual function, have a better outcome than, for example, nonsense mutation where no protein is available in the end. So the diagnosis, first we have the clinical presentation. Patients may have a failure to thrive, polyuria, polydipsia, dehydration, and fever episodes caused by dehydration. This is primarily caused by the Fanconi syndrome. Patients have phosphate loss, so they have rickets, and this is all caused by Fanconi syndrome. This occurs usually at the age of about 6 up to 8 months. And if we look at newborns where we know because of the family background they have cystinosis, some of them already present at the age of 4 weeks with some kind of aminoaciduria. So it's starting quite early, but it's demasked usually at the age of 3, 4, or 5 months. If the patient has the presentation, we go for biochemical diagnosis first. So we measure the cystine content in granulocytes. It's not done in the serum or plasma because cystine accumulates on lysosomes. So we use cells. So we use granulocytes taken from a full blood sample. And in heterozygous people, so for example, the father or the mother of the patient, the cystine content is usually below 1. And if the patients get diagnosed, patients have usual levels above 2, usually have levels above 4, and it's always related to the milligram protein content in the sample. And we aim for cysteamine in the cysteamine therapy for levels below 1. This is due to the fact that this is the level where heterozygous people have no symptoms at all. So that's why we aim to go for levels below 1. And in older children, sometimes we have cystine crystals in the cornea. So in the workup of the patient, the split lamp examination should also be done, and you can nicely see some corneal crystals, which please remember, may not be present at all, even if the patient is 12 or 13 months old. So we depend mainly on the biochemical diagnosis, and if available, it's recommended to confirm the diagnosis by genetic testing, which I just told you 1 minute before. So what about the pathogenesis of kidney disease? Yes, we know it's a proximal tubular dysfunction. Patients have Fanconi syndrome, but we know that there's also a podocyte disease. So the podocytes get also altered, and patients present with glomerular proteinuria. So if the proximal tubule does not work, we have tubular proteinuria by small molecular weight proteins, but patients often have a large proteinuria due to albumin, sometimes 2, sometimes also 4 grams per kilogram. And they may show in the biopsy, which we do not do regularly, but if we do so, some patients may even develop FSGS. Later on, as in other renal diseases, the pathway goes down to renal interstitial inflammation and fibrosis, and that's the way to the bad end. It's progressive kidney disease and end-stage disease, kidney disease. So we have first organ involvement, the kidney and the eyes, where we have photophobia. Later on, patients may have keratopathy and retinopathy, and the endocrine organs are often affected, like the thyroid gland. About 1/3 of patients have hypothyroidism, so patients should be regular checked for this. And patients may present with exocrine or endocrine pancreas deficiency. About 10% of young adults need insulin. And especially after transplantation, you have to take care if you give those patients steroids, so they may get overt diabetes. And the major problem, especially in males, is delayed puberty, which is on one side not good with respect to adult height, but it's also not good for bone development. And patients are often infertile as well. So about 1/3 of young adults need testosterone replacement therapy. And usually we say that all males with cystinosis are infertile. Of course, there are now case reports coming up that if you perform a percutaneous epididymal sperm aspiration, maybe followed by some high-tech application like ICSI, patients may induce a conception. So there are some case reports up to now, but usually male patients are infertile. And then the liver can be involved with liver enlargement. Some patients need even a liver transplant, which is rather rare, but this could happen. And then, especially in the adults, we have a progressive muscular disease, especially in the distal limbs and in the hands. So the grip strength gets decreased, and also in the second or third decade, especially in those patients with non-compliance or delayed start with cysteamine treatment, patients may have cerebral atrophy, neurocognitive deficit, pyramidal symptoms, and stroke-like episodes. I didn't notice all those adverse events from this disease in young patients before the age of 20 years during the last 20 years, but I know that many adult patients may show these problems. So cysteamine is available. It's a fantastic drug. This is again the lysosome. Cysteamine enters the lysosome by an unknown transporter, and cysteine contains of two cysteines, so they form together cysteine. If cysteamine complexes with cysteine, it gets divided by again in 2 cysteines, and one part of the cysteine gets bind with cysteamine and can leave the lysosome by the PQLC2 transporter, and the other part of the cysteine can just leave the lysosome by cysteine transporter. And if it's down outside the lysosome, it just gets into cell metabolism, and it's no problem at all. So the early studies were already done in the mid-70s of the last century. As you can see here, there's in vitro studies where you can see the intracellular cysteine content gets markedly decreased by application of cysteamine. And it's been available in many countries. For example, in Germany started in 1988, but in North America a little bit earlier, and some countries later. So now we have two forms of cysteamine available. In general, the dosage is given orally. Dosage is adapted according to body surface area between 1.3 and the maximum of 1.95 gram per square meter. So the old form, so-called, is the immediate release cysteamine, which has the drawback that it has to be given 4 times per day. And this causes sometimes adherence problems, especially in adolescents. Some patients have gastrointestinal complaints and halitosis because there's sulfate in it. And at least 2 hours after application of this drug, patients may have halitosis, which is rather unpleasant, especially in adolescents, which may find their peers, and a bad breath and skin smell. So now in the last years, there became extended release cysteamine available. The dosage is a little bit less compared to the immediate release medication. The advantage is that we have to give it only 2 times per day. That's good for the compliance, and the proton pump inhibitors, which are usually mandatory in patients receiving immediate release cysteamine, are not required, and it may be also given by PEG. The drawback of this drug, it's quite more expensive. So the target in the treatment is cystine contents below 1 nanomole per half cystine milligram protein. And it's always a question how often we measure the levels. It's depend on the adherence of a patient. But please remember, if the patient does not take the drug and just starts a few days before he enters your outpatient clinic, the cystine content levels are fine. So this does not prevent non-compliance. And maybe it's good not to mention to the patient when you do the blood tests. Of course, patients need a lifelong treatment, and especially it must be continued after renal transplantation. The good news, since it's a disease in the cell, the disease does not recur in the renal transplant, but of course in every other cell of the body, the disease persists. So we measure the leukocyte content 6 hours of the last intake in the immediate release cysteamine drug replacement, and for extended release cysteamine after 2.5 hours. And unfortunately, the systemic treatment does not enter the eyes, so we need a topic treatment. Formerly, there was only the 0.5 drops available, eye drops available, which have to be given 2 hours. And to be honest, none of our patients could manage it in the end. We say poor compliance, but I also would not be able to give me eye drops every 2 hours. So there's a new gel formulation available, which may be given only every 6 hours, which has an excellent efficacy. And this is really an improvement for our patients. So this slide shows you a little bit on the pharmacokinetics. You see here the pharmacokinetics of the immediate release cysteamine with the peak after 1.2 hours, and the extended release cysteamine, the peak after 3 hours. And you see for many hours it stays in the blood, and the cystine contents only starts to rise after 8 up to 12 hours. That's why EMA licensed this drug to be given just 2 times per day. So in the first study, which was coordinated by Dr. Langman from Chicago, they performed a randomized crossover trial with the immediate release drug and the extended release drug. They call it here a delayed release, but a delayed release and extended release is the same in the end. And then they did a crossover after 3 weeks, and after that, there was the extension study. And this was a non-inferiority trial, and the study was positive, meaning that both drugs have the same efficacy. However, patients on extended release cysteamine didn't need the proton pump inhibitors, and the dosage was in the end a little bit less. And The long-term outcome was quite positive. There was a sustained leukocyte cystine level content lowering effect. Patient had stable GFR, and there was an improvement, significant improvement in social function, school function, and total function scores on the pediatric quality of life, which was mainly due to better, less frequent application, and some patients showed or reported on less halitosis as well. So, so what is our experience? When the drug became available in Hanover, we approached our 13 patients with cystinosis and told them what were maybe the advantage and what may be disadvantage. And then 11 out of our 13 patients said, well, let's try the new immediate extended release cysteamine. And the most common reason was difficulty with night administration. Some patients complained also on halitosis, and one patient had just high white blood cells levels. So this was the reason for that. And before on immediate cysteamine, many patients complained of halitosis. And then we started with the first patient. And this was not really an excellent case, because the patient had vomiting before, but the vomiting even got worse on the under extended release cysteamine. So we switched him back to immediate release cysteamine, but the vomiting continued. And then in the workup, it came out that he has an hiatus hernia. So it's always good to remember that maybe other causes of vomiting in those patients. And then the next patients, he also switched back, but then he said, well, maybe it's better to go back to extended release cysteamine, and except one other patient, all other patients stayed on immediate release cysteamine. So in the end, 8 of our 11 patients said, well, it's better, let's stay on extended release cysteamine. And 4 of 6 of our older patients being able to report, they reported that halitosis and or bad breath was reduced or even eliminated by the new drug. So that's our brief reports. And here are the leukocyte cystine levels in our lab. The target is below 2. And as you can see, at the time of start of immediate release, extended release cysteamine treatment, 1 patient had markedly elevated levels. They were nicely coming down, and the other patients were rather stable. However, it's a small number of patients. So what is the outcome? And I'm very proud, and it's a privilege for me to show you some slides provided by Professor Francesco Emma from Rome, Italy, who coordinates the UNEFRON cohort. It's a cohort about more than 300 patients from 6 European countries, where we say, well, there's all centers of excellence. So we say, well, that's probably patients are treated quite well. And as you can see, the renal outcome, that's the 1-1 probability for end-stage kidney disease, was markedly improved from the 70s, 80s until 2000. And if you look closer at the numbers, you can see that the mean age at end-stage kidney disease improved from 10 years up to 18 years nowadays. That means that 50% of the pediatric patients which need transition to adult nephrologist, we transfer with preserved renal function without renal replacement therapy. So the whole picture changed when I started in nephrology. All of our patients were end-stage kidney disease when at transition. Now it's a complete new picture. Of course, if patients get started early, it's a better outcome here. The number was used plus or minus more or less 1.57 years with a better outcome. And if you look closer, you can see that it's a difference of 4 years with respect to end-stage disease. But that's just not the whole truth. If you look closer to the data, here you see the reference with 1.57 years. You can see if patients get treated earlier, the renal outcome is even better. So it's not just 1.5 years or 2 years. Every month count in the end. So if patients get started on the drug 2 or 3 months earlier, it's better for the long-term outcome. So having said this, it's quite reasonable to check patients quite early. And in Bavaria in Germany and in Lower Saxony, Katharina Hohenfelder initiated a screening project, and this is an ongoing research project where patients get screened, all newborns get screened. It's a population about 20 million people in Germany, and all the newborns get screened. And by doing this, we aim to identify children early, even if there's a negative family history. So the good message today is that if you do a renal replacement therapy, the outcome is quite good, especially patients getting transplanted have even a better graft survival compared to non-cystinosis patients. Some of us believe it's true that the compliance is better because they were used to take 8 drugs 4 times a day, so they just take the 2 drugs 3 times a day or 2 times a day quite easily. But there may be also other causes for that. So the next focus will be on the bone disease, and I would like to show you some slides from a recent consensus paper, an international consensus paper on the management of bone disease, which I had the opportunity to contribute to this. And the bone disease in cystinosis is due to hyperphosphatemic rickets, and patients with cystinosis maintain to have phosphate loss even in CKD stage 4. So this is always present. And then if the patients have entering advanced CKD, they get in addition the consequences of chronic kidney disease, which we usually call CKD-MBD. And to bring this together, we coined the term cystinosis metabolic bone disease. So the clinical presentation, I just told you, patients have short stature, osteomalacia, bone deformities, bone pain, or also maybe osteoporosis. Children have rickets. Adult patients have, of course, osteomalacia. And adult patients may have bone fractures and scoliosis. And we know that in adults, up to 40 or 50% of the patient have severe bone problems. If patients are started on cysteamine, the growth can usually stabilize. And it's mainly due not to the improvement of the Fanconi syndrome, but it's rather to the stabilization of kidney disease. So here you can see that's the effect of Fanconi syndrome, and that's the effect if you have Fanconi syndrome and advanced CKD. So you see that's the national cause, and the growth is much better. If you do a bone biopsy, patients usually show a mineralization defect, which is indicated by increased osteoid. That's the orange staining here. And people may have genovara or genovalga, adult patients fractures. And with the pathophysiology, I may say that the renal Fanconi syndrome results in hyperphosphatemia, acidosis, and diminished 125 vitamin D synthesis, and consequently hyperphosphatemia. And in addition, patients may have malnutrition and copper deficiency. There's hormonal disturbances like hypothyroidism, hypogonadism, hypoparathyroidism, and as in other patients with advanced CKD, patients may have growth hormone and IGF-1 resistance, and older patients especially have myopathy. And in addition, we know from knockout models that knockout of cystinosin results in an intrinsic osteoblast and osteoclast defect, which is add-on. So we see it's a lot of things going on, and we have to, I'll just skip this for time reasons, and we have to take care for all of this. So first, what we have to do for the management. We focus on the Fanconi syndrome. So patients need free access to water and toilet. They may need up to 8 liters per day. They need they need adequate nutritional support, at least 100% of the recommended dietary intake in healthy children. Many small children need nasogastric tube or PEG. Please be proactive, don't wait too long, because it doesn't get better if the patient has growth retardation and you delay PEG treatment, the growth outcome will be less. And if we want to perform a renal transplant in patients need to be in a good shape. We have to supplement electrolyte losses. Please have free access for the patient to salty food, and they need additional sodium chloride. So we should take care that the sodium and the chloride levels are in the normal range. Many patients also have vomiting, so they need maybe more sodium chloride. Of course, if you give too much sodium chloride, the vomiting will also increase. So it's a delicate balance. Potassium demands are quite flexible, between 2 up to 6 millimole per kilogram, and we are quite happy if we keep the serum potassium levels above 3. So if patients have severe polyuria, cannot be managed conservatively, some physicians recommend to treat the patient with indomethacin. There are no controlled trials with using this drug, but it seems to be safe, and the dosage is between 1 and 3 milligrams per kilogram per day. Phosphate is very important, so patients have hypophosphatemic ricket. We start with a dosage of phosphate based on elemental phosphorus above between 30 and 40 milligrams per kilogram. Please give frequently phosphate throughout the day. Maybe just give the phosphate solution in one bottle and the patient just drinks it over the day. And the treatment needs to be individualized in order to control rickets, and a wide range may be used. And in the end, like always, the minimal effective dosage should be used. And of course, if patients have advanced CKD, they may need less phosphate, and we just check the serum phosphate levels. The acidosis need to be treated, and we aim for at least 20 millimole per liter. If it's very good, we have above 22 millimoles per liter as in other patients with CKD. So what about calcium active vitamin D? What about active vitamin D? Why is it necessary? Well, there are some reasons for that, good reasons for that. First, cystinosis patients have diminished calcitriol production. So we need calcitriol to counter calcitriol deficiency, and we need to prevent secondary hypothyroidism, because if we treat those patients only with phosphate and not with active vitamin D, maybe PTH goes up, and then we have phosphate leakage in addition, driven by hypothyroidism. And the third reason to give active vitamin D is to increase phosphate reabsorption from the gut. So what we aim for, we maintain the lowest possible dose with active vitamin D to treat rickets and to keep PTH in the CKD stage-dependent target range. I will show you in a second. And then, like in other CKD patients, we have to check a native vitamin D or supplement. And if patients have persistent hypercalcemia, it's recommended to give calcium supplements, but don't give calcium supplements together with phosphate. It will always be separated. So what is the recommended PTH levels in patients with CKD stage 1 to 2? The levels should be in a normal range, and in advanced CKD, the PTH levels could be recommended, could be maintained in the CKD stage dependent target range by dietary measures, active native vitamin D, and maybe also calcimimetic and or phosphate binders. You know, there's a huge discussion going on. I don't want to enter the discussion. So in North America, it's believed that the levels, depending on the stage of CKD, should be between 1 and 3-5-fold increased compared to normal. In Europe, in children, we believe that between 2 and 3 times is enough, and we live on this. But in the end, we don't know what it's really the optimal PTH levels for several reasons. And if patients show persistent growth failure, defined as the height below the 3rd percentile and the height velocity below the 25th percentile. It's recommended to start patients on growth hormone with a regular dosage as in other CKD patients. We have to take care. I told you that cystinosis patients may get diabetes, so especially in adolescents, you have to check their HbA1c levels. And as in other patients, the treatment should generally be stopped after transplantation, maybe reinstitution if there's catch-down growth after transplantation. So sex hormone treatment may be especially required in about 1/3 of young adults or in some adolescent patients presenting with pubertas tartar, which could be done by a testosterone patch or intramuscular treatment. L-thyroxine may be substituted in case of hyperthyroidism. And as stated before, for the bone, it's very good if you keep an optimal control of the leukocyte cystine content levels. So in summary, the major goals: avoid dehydration. We want to heal rickets, so the clinical and radiological signs of rickets should be improved. And we want to have alkaline phosphate levels in the normal range or slightly increase. Growth within the lower normal range is a goal. And please remember, normalization of serum phosphate and potassium levels are not a goal. So this is always a leakage. And if you cannot normalize phosphate levels, it's not recommended to increase the dosage, and the same for phosphate and potassium. And of course, adapt the medication in patients with advanced CKD. So in the next 3 minutes, I would like to share you some outcome data, which was done or summarized by a multi-center study in 10 German centers. And so we did a cross-sectional multi-center study. It's a part of an ongoing prospective study, and we have included 49 children with nephropathic cystinosis, irrespectively of the degree of renal insufficiency. And we had 80 CKD controls of the same age and CKD stage, because we wanted to compare the bone disease and the alterations in mineral parameters from cystinosis patients with children with CKD to distinguish between the effects of Fanconi syndrome and CKD. So what we did, we measured some fancy bone markers, starting with FGF23. It's a bone-derived phosphaturic hormone, which gets elevated in early stages of CKD to keep on a normal phosphate homeostasis despite decreasing GFR. So it rises already at CKD stage 2 usually. And we measured the soluble form of the FGF23 co-receptor chlorotho, which is produced by the kidney, and it can also be measured in blood. And then we used the bone alkaline phosphatase as a marker of bone formation and mineralization. And then we measured the citrate-resistant acid phosphatase 5b, let's say TRAP5b. It's a marker of bone resorption since it's produced by osteoclasts. And then we measured sclerostine. This is a very interesting marker. It's also secreted by osteocytes, and it's a bone remodeling inhibitor. And we now know that in patients with CKD, early stage of CKD, sclerostine is elevated, and it may cause early bone loss in patients with early CKD in children and adults. So it's a very important marker. And then we measured also all the common markers of mineral metabolism, and then we correlate everything with the skeletal comorbidity. So that's our population, and I would like to focus that the age and GFR was comparable, and as expected, the patient with cystinosis due to Fanconi syndrome, that's the pre-transplant group, cystinosis controls, and here's always the p-value given. You can see that patients with cystinosis were more frequently of phosphate, potassium, and calcium supplements, and calcitriol and bicarbonate, which is quite reasonable because of the Fanconi syndrome, but they also required much more often growth hormone treatment. Despite this, patients with nephropathic cystinosis were significantly shorter. So the prevalence of short stature was 43% compared to 9%. This was still a little bit true after transplantation, but was more pronounced in the pre-transplant group. Patients have much more frequently clinical signs of rickets and more frequently requirement of surgery and skeletal deformities. About 40% of the cystinosis patients presented with genua valga, genua vara, and some also with scoliosis, whereas in controls, this was not observed in the pre-transplant group and in only 2 out of 36 patients after transplantation. When we did the multivariate analysis, it turned out that nephrocystinosis was associated with increased risk for the development of short stature, bone deformities, and or surgery with an odds ratio of 11. So it's a much more increased risk for these patients. And we also observed that treatment with growth hormone was associated with a lower risk for short stature when we looked just for the cystinosis population. So this drug works quite nicely in these patients. And despite the treatment of Fanconi syndrome, patients presented more frequently with hypophosphatemia, hypocalcemia, acidosis, hypokalemia, and a little bit unexpected, although the mean PTH levels did not so much differ in the recruitment group, the percentage of patients presenting with PTH levels below DOKI target range was significantly higher in the cystinosis group. So the patients had a tendency for hypoparathyroidism. And maybe because physicians may look more frequently on vitamin D levels, vitamin D deficiency was less frequent noted in cystinosis patients. So let's look a little bit on the serum levels. Here you can see the serum phosphate levels in cystinosis patients compared to controls as a function of GFR. And if patients had received a transplant, as you can see, the phosphate levels were markedly diminished in patients with cystinosis compared to controls, but did not differ in patients with advanced CKD. And interestingly, after transplantation, the controls showed post-transplant hypophosphatemia. We know this. This may happen, but in cystinosis patients, there was even a tendency for higher phosphate level. And here you can see the serum PTH levels compared to the CKD-dependent PTH target range levels. You can see that the patients with cystinosis were quite comparable. However, after transplantation, the PTH levels in the cystinosis patients were just in the mean of 45. That's in the lower normal range. And in the controls, they were slightly elevated. And this may be a cause for the rather high phosphate levels in the cystinosis patients, the low PTH levels compared to the controls. When we look further, we look at FGF23, and as expected in early CKD, in the controls, you see that FGF23 levels start to rise. So they are elevated once the SD, the GFR above 60, and if the GFR is between 30 and 60, they are elevated around 2 standard deviations. By contrast, in cystinosis patients, the FGF23 levels were in the normal range until advanced CKD defined the GFR below 30. Interestingly, after transplantation, higher FGF23 levels persisted in the controls, but cystinosis patients had rather low FGF23 levels, and this may be an additional cause for the rather high phosphate levels we just saw a minute before. So in the end, there's a delayed increase in FGF23 in cystinosis. When we did the multivariable analysis, we observed that the phosphate levels were correlated independently with GFR, which is reasonable, but also with phosphate SDS and with calcium serum levels, which are all known factors to stimulate FGF23 synthesis in osteocytes. And then we come to the interesting part with the sclerostin. As expected in early CKD, sclerostin levels were increased about 1 SD in the controls and kept increased. By contrast, in cystinosis patients, the sclerostin levels were lower. Why is this? And we speculate that we know that patients with cystinosis may have an osteoblast defect, and we know that sclerostin is a negative modulator of bone formation, and this may be a compensatory mechanism in order to increase osteoblastogenesis. And then we come to BAP, which is a bone formation marker, and patients with cystinosis had significantly higher BAP levels, and however, these were rather normalized after transplantation. That's the good news. So why are the BAP levels elevated? So elevated BAP levels may reflect increased growth, hyperparathyroidism, or mineralization defect. So since the cystinosis patients showed poor growth and rather low PTH levels, the reason for the increased BAP is presumably or most likely a mineralization defect, which gets better after transplantation. And then we come to the TRAP, that's the last marker. TRAP is a marker, a bone marker synthesized by the osteoclast. So if you have a high number of osteoclasts or increased function of the osteoclast, TRAP levels are increased. First, we look at the control. We see that the TRAP levels were rather in the normal range, which is a little bit expected since our patient cohort with the CKD controls did not have severe secondary hyperthyroidism. So that's expected. But if we look at the cystinosis patients, in those patients with preserved renal function or normal renal function, they presented with markedly elevated TRAP levels, up to 2 standard deviations elevated. This may suggest that those patients with cystinosis may have an increased osteoclast function, indicating a bone resorption. And even more important, the increased bone resorption continues after renal transplantation. So this increased bone resorption may persist after transplantation in our patients. So I would like to summarize that despite rigorous treatment for Fanconi syndrome, nephropathic cystinosis patients show a markedly increased skeletal comorbidity associated with distinct CKD stage-dependent alterations in bone and mineral metabolism compared to CKD controls. Our data suggest a persistent impaired bone mineralization and increased bone resorption in cystinosis, which is only partially normalized after transplantation. Taken together, this supports the concept that cystinosis-associated metabolic bone disease is not only related to the consequences of Fanconi syndrome and mineral and bone disorders related to progressive CKD, but also to a primary osteoblast and osteoclast defect. So that's the last slide where we started with the history. So this was a patient I took care when I worked in Berlin in the early 2002. This was a very lucky young lady with cystinosis. She was very lucky because she could give birth to a healthy son at the age of 23 years when she was on hemodialysis. And she was started on cysteamine treatment quite late. That's why she had end-stage renal disease quite early, and she has rather a poor growth outcome. However, she was happy because she had a healthy son. And this is a patient now, a more actual patient. He was very lucky because he had an excellent mother. His mother noticed that at the age of 8 months, he had clinical symptoms. She went to a physician. The physician said, well, everything is fine. This will fade away. But the mother was rather smart. She went to Hanover Medical School and presented the child, and the child was quickly diagnosed with cystinosis. And then 20 years later, the patient is now 26 years old. He has preserved renal function. He's a student of business administration. He even thinks about family planning. So we did the sperm cryoconservation because he wants to become father in some years. And of course, he has a medication as in other patients with preserved renal function. Don't forget, this is not only a one-man or one-woman show. This is the treatment requires a team, a multidisciplinary team, which is not easy to provide because of the cost restriction, because the health insurance usually don't give enough support to provide this, but we try to do our best to provide a service by pediatric nephrologists, to provide a transition to the adult nephrologists. We try to keep care for all those complications I just told you. And having this, I would like to finish, and I would like to thank you for your attention. Thank you.
Thank you very much, Professor Hafner, for an elegant presentation on rare condition cystinosis. We have enjoyed the talk, and I think there are a few questions that I wish if you can together entertain in the next few minutes. Let me start by asking regarding the podocyte injury in cystinosis. You have clearly defined the FSGS lesion. Now, we don't do renal biopsy often in patients with cystinosis. How common do you think this lesion, and does it happen usually after the Fanconi tubular disorder, or it can start by FSGS and then Fanconi comes later?
So I have to admit that I never did a renal biopsy in a patient with preserved renal function opposed to cystinosis, but I know that all patients present Fanconi syndrome. So that's the first thing. And sometimes if the patients have advanced kidney disease and get diagnosed late, people may perform a renal biopsy and then they can see FSGS. But in the end, as we learn the genetic form of FSGS, immunological form of FSGS, this is just a collagen deposit and it's just an endpoint. So it's not specific. And I think it's just describing that the disease is not only to the proximal tubule, but other cells are getting also involved.
Excellent. Thank you very much. One of the audience or participant is interested to hear from you about, would you suggest a protein kind of supplement or a special type of diet for patients with cystinosis to improve the growth?
So in general, as in all children with kidney disease, we first start to recommend a regular diet like in healthy children. And we know that many healthy children do not get a healthy diet sometimes. So we first start to get rid of all the industrial food and try to give, like we hopefully both get food from our mother some centuries ago. This is the best thing, and then we start with that. And if we still have low phosphate, which is of course due to Fanconi syndrome, we add on this phosphate supplements. With respect to the caloric intake, we aim for at least 100% of the recommended dietary intake as in healthy children, and we may increase this up to 130%. Usually the problem is that if you give much more energy, then you get hyperosmolar feeding by PEG, and then you get hyperosmolar diarrhea and vomiting. So I think it's not a good thing to get a more and more amount of food. But if the child is not drinking enough, not eating enough, and if it's small, we are proactive for a PEG. And then if we go for 100, 110%, give it in several times a day to reduce vomiting. Maybe patients need fundoplicato, like in other young children. Most of the children are doing fine. However, in our North European cohort, about 50% of the patients required additional growth hormone.
And in addition, I believe in our practice, we do insert a G-tube for feeding sometimes because of the frequency of medications, as well as the sometimes night feeding with tube feeding. It's very helpful, I believe, right?
Yeah. So you know, when I started nephrology, we had an nasogastric tube feeding, and nowadays many people say, well, there's a risk of aspiration and blah 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 blah. So that's why we use the bottom or the pack, the gastrostomy nowadays. But both is in the end fine, and it's not so much dependent what you do, but the matter is to get enough energy. Of course, there are many ways. I fully agree.
Yes, and in this part of the world, probably in the Middle East, regarding WB system, measurement of WB system is quite difficult, and we don't have yet a lab that is really certified or able to do the test. So in the past, or still until now, we send the samples sometimes over to Europe or to the States, but it's a time limit. You know, blood, if it's sent for WB system, you need to be within 24 hours, I guess. And this is very, very difficult. So this is one of the issues that some of the participants would like to hear from you, since this is very difficult to measure WB system in a regular basis. What kind of alternatives do we have to assess the effect of treatment on that growing child with cystinosis, please?
My approach would be the other way around. So if you don't have the leukocyte cystine contents measurement available, I would just start with a reasonable dosage of cysteamine. Usually we say between 1.3 and 1.95 gram per square meter. So I just would go for 1.6 or 1.7 or 1.8. And there's no, usually we never had the problem that the cystine levels were too low in our patients. To be honest, usually in most patients we go for 0.8 gram per kilogram and per body surface area, and we are happy if the leukocyte content is coming down. And I know that many specialists around the world say, well, it's so stupid, don't do 1.3 and 1.4, just start with a good dosage and keep it up. And if you cannot measure it, just keep up the dosage, 1.8 gram per body surface area. This is probably fine. In most of my patients, I end up with the same dosage in the end, and I'm happy if the leukocyte content is fine. And there's there are some reports on toxicity, but usually it comes from the time when people further increase the dosage. So I think it's quite safe. Okay.
One of our colleagues is asking, in your study where about soluble clotho, is asking, as you monitor soluble clotho in the study, are you able to further prove this concept, and what was the findings?
Yeah, I omitted the slide because of time reason. Soluble clotho. Well, the concept and the slides you get presented are always showing that clotho is synthesized by the kidney, and it gets shedded and in the soluble form, and it's in the blood, and it gets reduced if patients have more advanced CKD. However, there's not a good correlation between the GFR and clotho levels. And in my studies, which I performed in children, in about 60 up to 120 children, I did not find any correlation between serum clotho levels and GFR. And in some patients on dialysis, the clotho levels were low. And in this study with 50 cystinosis patients and 180 controls, the clotho levels were in the lower normal range in both cohorts without any differences. So this may be due since maybe there's no correlation between the clotho in the kidney and the blood levels, but maybe also an assay problem. So these are all ELISAs, and we are not sure what they are measuring in the end. So it's with clotho, it's not easy. And if I show my presentations for CMBD, I always have the slide where clotho goes down and so on, blah, blah, blah. This is all nice, but in reality, it's not so easy.
Yes, yes. One of the question is as we are using vitamin D for patients with cystinosis, we do see a number of nephrocarcinosis. Some patients, they have maybe in my patients population, I see it more than or around 50% actually. What is your advice in that regard? I mean, we do measure calcium creatinine ratio in the urine, but it's always difficult. I mean, those patients need vitamin D. So Absolutely. Is there any special advice, please, on this regard?
This is an excellent question. I like this question because I asked myself this question some years ago, and also asked my professor when I was young. So he explained to me, he said, well, Peter, you measure the calcium creatinine ratio. This is usually not really high. And please remember, they have an intake of about 6 up to 8 liters. So the urine gets diluted. Why should they get really severe nephrocalcinosis? And in about 20% of the patient, we see some kind of nephrocalcinosis. That's not good evidence, but due to the fact that the patients have polyuria, I believe that the risk of advanced nephrocalcinosis, which may impair renal function, is rather low. On the other hand, what really matters in those patients is the vitamin D deficiency and the tendency for hypocalcemia and the hypophosphatemia. And I usually am rather proactive in these patients, starting with 0.5 microgram calcidiol, usually in those patients, and in order to also increase the phosphate reabsorption. So I'm rather reluctant, and I'm rather giving a pretty much amount of active vitamin D in this population. However, when we did the analysis, we saw some correlation between PTH levels and calcitriol medications. So if you give calcitriol and the patients have hypothyroidism, it may be too much. So maybe in those patients, we have to decrease it. In my clinical practice, I remember some adolescents which were rather doing poorly with cystinosis. They have persistent hypoparathyroidism, and they had poor compliance, and I believe it's not evidence-based that the hypoparathyroidism may be also due to involvement of the parathyroid gland as well. So sometimes, at least in older patients, it's not easy to differentiate. Is it our treatment overtreated, or maybe just a natural cause from the parathyroid gland? So it's tricky. Yes. But I think it's good to give active vitamin D.
We haven't touched base on the ophthalmic cystinosis type. In my experience, I have seen a patient with ophthalmic cystinosis. When we did the genetic mutation, he was homozygous. Is that what your experience? I mean, the ophthalmic cystinosis, are they homozygous in their mutation? And then when should we anticipate renal involvement, if any, in the future for those patients?
That's an excellent question, and to be honest, I never had a patient with restricted eye involvement without Fanconi syndrome, and this patient had also normal leukocyte cystine content or increased?
Yes, he has normal leukocyte content, cystine content. Yes.
So I never had this, and if you have proven maybe there's a rather mild mutation with a good outcome, I would recommend, of course, topical treatment. That's clear. But
For sure.
if the leukocyte content is normal, I will not be proactive for giving cysteamine, but I will closely monitor the patients. And also a dipstick for glucosuria, aminocyturia will maybe also be good. But what did you do with your patient? Maybe more interesting to do. What did you do?
Yeah. Actually, he had to go to London to get the WB cystine level done. And when it was normal, we just treated him with ophthalmic eye drops. I mean, ophthalmic cysteamine, because there was no indication there is any other systemic illness. He's an adolescent. He's almost now 16, and he's doing very, very well. The only thing is that, you know, he was complaining of photophobia. That's what drew our, you know, attention to what's going on. I mean, his parents, you know, they did watch that, and then they seek some medical advice. That was very, you know, I mean, still it's an interesting case, and I was hoping to hear, you know, more about ophthalmic cystinosis patients. There is one question coming here, is asking about, is there any maximum dose, back to vitamin D, is there any maximum dose you should be, you know, you should monitor the PTH, I guess, and the calcium level? Is there any maximum dose for vitamin D in cystinotic patients, please?
So, you know, 30 years ago, we were rather giving high levels of active vitamin D in our patients, and in CKD patients, we know that if you give 1.5 microgram in the adolescence, it may increase the calcification of arteries. So, but they have in combination hyperphosphatemia. So, having said this, we tend to use rather moderate levels of dosages of active vitamin D, and I usually go up to 0.75 microgram with calcitriol, but usually it's calcidiol which I give, and it's usually 1-alpha, about 0.75 microgram, and this is usually enough. So I have a tendency, you know, 20 years ago, when I started this, we had calcitriol 1.5 microgram. Nowadays, we are stopping at about 1 microgram or 0.7 microgram. That's not evidence-based, but that's quite a good dosage, I think, and it's probably enough, and there's no reason to give much more of this drug because we don't know what will happen.
Okay, maybe the last question, actually, you know, the audience and participant would like to hear if what's new about, or what's the most update about the bone marrow transplant in cystinotic patients. Do you think this is a promising, it's a promising treatment in the horizon, or what is your view on this, please?
I'm not sure. I have to confess, I'm a simple-minded pediatric nephrologist, and so my knowledge about this experimental approach is rather poor. So I think I would rather like to know more safety data and efficacy data. It's rather experimental. Maybe you know, it's always difficult to assume what will show the future, and there are many approaches now getting tested in the labs. So I'm not sure. I'm a little bit hesitating to do this experimental treatment in my patients if I have no data on the side effects and what will happen, and patient may die. I don't know. So I hope that it will work out very well in future, but I am not sure, and I would like to wait really good clinical studies where the outcome is thoroughly checked.
Professor Dieter Hafner, it's been a pleasure entertaining your lecture this evening, and we really, on behalf of the participant, the Saudi Society for Nephrology and Renal Transplant, I'd like to thank you for your time, for your explanation, for your thorough description of the condition. And we hope we can get back again in the future for more further scientific activity. Thank you very much and good night.
Thank you very much and good night, and see you soon, and please stay healthy. Bye-bye.
Bye-bye.
Bye-bye.